Workforce Solutions Department. As promised, you'll see that we have Tonika Robinson. I saw her log on earlier. Welcome, Tonika, who will be talking to us about the Mental Health Services Act, which coordinates behavioral health responses throughout the county. And then we have Marcus Cannon, Deputy Director over the forensics team at Behavioral Health, that will be highlighting the HOPE program. We want to encourage you guys to go ahead and use the chat box to both introduce yourselves. If you haven't already, type in your full name, title, and the organization you're representing. It's the way that we capture attendance. And also use it to type or enter any questions that you have as the speakers are presenting. We want to encourage the speakers to look to the chat box to answer questions during their time. And then if we have time at the end, you'll see that we've allocated 5 minutes, which sometimes we have and sometimes we don't, which is why I want to encourage you guys to take advantage of the time when they are live. So with that, we'll go ahead and get started. Welcome, Tonika. Thank you for reaching out and making this presentation available to our continuum of care. Thank you.
Thank you so much for having me here today. As mentioned, my name is Tony Robinson. I'm the manager of innovation and cultural competency here at Riverside University Health System Behavioral Health. I'm here with you today to talk about our Mental Health Services Act annual plan update. So every 3 years, we have to write a behavioral health plan that covers the Mental Health Services Act and submit it to the state. We do a lot of stakeholder input. We gather feedback from the community. So the community actually influences our plan writing. We take all the community ideas, put it together with our expertise knowledge, and create programs and projects to serve Riverside County when it comes to behavioral health. This portion of the department, which is the Mental Health Services Act. So we do that every 3 years. And then in those interim years, those years in between, we also have to put together an annual update that says what we've done so far on the 3-year plan and what we plan to do in the upcoming year. And so this happens to be one of those annual years. Next year, we'll probably be coming back to you with a more robust stakeholder process to get the information for the 3-year plan. But this year, I'm updating you on what we've done so far, what changes have been made, and seeing what we might want to do in the future. And so the whole purpose of this presentation is to let you know what's going on with the Mental Health Services Act in Riverside County and to gather your feedback. And so I'll be talking about ways that we can gather your feedback as well. I see the first slide up, so I'm not sure if someone has the presentation. Oh, okay, it's working for me, because I was going to say we've been having a little bit of internet problem. Okay,
I have it,
having some
Tony.
internet
Just let
issues.
me know when to advance.
Got it. I was going to have to turn my camera off to make sure that I didn't cut out while we do this, but now you have the pleasure of still getting to see me while I speak, and I don't have to worry about moving the slides forward. So what is MHSA? MHSA is exactly what I just stated before, the Mental Health Services Act. It was a proposition in 2004. It was Proposition 63, and the voters approved it. What it is a 1% income tax on all, they call it the millionaire's tax. So everyone who makes over $1 million, 1% of that state tax goes towards mental health services used to transform public mental health. And so MHSA has rules and regulations about the limits and the possibilities and how the money can be used. It cannot pay for any involuntary programs. It cannot supplement existing funds that we already have. It cannot be used on our substance use or substance abuse disorder programs unless there's some prevention or early intervention assigned to it. And it's a central element for county collaboration. So we use MHSA funding to collaborate with a lot of community stakeholders. The overarching goal of MHSA is to have more community involvement when it comes to public health. Next slide, please. So Community collaboration, the stakeholder process, which is what we are doing today, is community program planning process where we gather feedback. We do gather feedback year round, but this time of year is when we kick it up a notch and we ask for you to submit forms. We ask for you to submit suggestions. We ask for you to let us know what we're doing well and what's working in the community. We also ask for you to give us information about what might not be working so well so that we can think about ways to change that in our upcoming plans. As I mentioned before, there are two types of plans, which is the 3-year plan and the annual update. We're currently doing the annual update. Next slide, please. So there are 5 components to MHSA. 1 is community services and support programs. 2 is prevention and early intervention. 3 is innovation, which is the team that I manage. 4 is workforce education and training. And 5 is capital facilities and technology. I'm going to go through each of these. I know that our presentations are generally long. I know I have 25 minutes, so I'm going to narrow down some focal points while going over these 5 components. Next slide. So CSS, that's the community services and supports. So it's the largest of all the components, which means it gets the most amount of funding. It's integrated mental health and support services for children, TAY, adults, older adults, the whole gamut. Our full service partnerships are over 50% of our community services and supports. We do clinic expansion. It also includes housing, and that's the portion that we're going to that you all would fit into this group. So it includes housing, our H-Hope services, our crisis systems of care, our mental health courts, our justice involved programs. So some of the updates that I have for community supports and services. For our full service partnerships, in addition to our already existing FSP programs and the outpatient system, FSP services expanded to outpatient clinics across age groups countywide. So there's now outpatient clinics across age groups countywide. As a result, some FSP bridge programs were eliminated the service was integrated into the FSP outpatient track. So some of the bridge programs were eliminated, but they were absorbed into the outpatient track. And so I just want to make sure that that's an update that everyone knows, because some people might think that we are losing programming, and we're not. It's just absorbed into another part of our program focus. We have a mobile crisis management team, and they're expanding. Specialty crisis management teams that incorporate crisis, substance use, and homeless outreach expertise on one multidisciplinary team. The program expanded from the 1 team in Lake Elsinore to additional teams in Paris, Desert Hot Springs, and Harupa Valley. Our CBAC teams, and those are the teams that work with different police departments or sheriff departments. There's an expansion there too. Our police officers and clinical therapist partnership teams that respond to law enforcement dispatch, behavioral health related calls have expanded to include all of the following law enforcement agencies. I have a list here: Menifee PD, Corona PD, Beaumont PD, sharing with Cabazon Sheriff, Cathedral City PD, Palm Springs Sheriff, Hemet Sheriff, Harupa Sheriff, Parish Sheriff, Thermal Sheriff, and Lake Elsinore. So that's a huge deal. Now we will have clinical therapists with the police officers and the sheriffs when they receive behavioral health calls. Let me give you some updates that I also have listed here on the peer center developments. There are 4 locations for peer support and resource centers, and those have been determined as one being in Riverside, here at 2085 Ruston Avenue, which is where I'm located. 1 in Temecula at 40925 County Center Drive. 1 in Paris at 450 East San Jacinto Boulevard. And 1 in Indio at 44199 Monroe Street. So that's the update that we have on peer centers. And we have those in the Mid-County region and the Western region, and in Temecula and Indio. And so Indio is actually the desert region. So we have them in all three regions of the county. And that's what I have as updates on community services and support. Next slide, please. So PEI stands for Prevention and Early Intervention. It's the next largest component of funding that we get for the Mental Health Services Act. The purpose of PEI is to reduce stigma and help people link to services, reduce discrimination of people with diagnosis, and prevent the onset of a SMI. So early intervention for people with symptoms for 1 year or less, or do not meet criteria for diagnosis. So low intensity, short-term intervention. Services for youth under age 25 is at 51%. What that means is that PEI looks 51% of the funding that is used for prevention and early intervention must be for youth and TAY age individuals. And so that TAY age is from 16 to 25, and the youth is anyone under 18. So 51% of funding for PEI must be used on those populations. PEI has 7 different work plans. I'm going to give you updates on a few of them. We will start with work plan 1, which another portion of my job, it falls under cultural competency. So I manage that team as well. Some updates that we have for cultural competency over the past year is that we have expanded. We have gone from having 3 community liaisons on board for 3 targeted populations to having a total of 10. We have 9 new liaisons. The 10th is our veteran service liaison. That person's position was moved under cultural competency because we recognize that veterans are a population that has been underserved or inadequately served in the past. And so cultural competency has taken on the responsibility of making sure that our veteran outreach is as fluid as it is with other populations. And so again, we now have a total of 10 with veterans. We also added on, so we already had Native American, African American, and Asian American Pacific Islander. We have added on the Latino, Latina, Latinx population, the LGBTQIA plus population, deaf and hard of hearing population, the Middle Eastern North African population, spirituality and faith-based population, and the people with disabilities. So we have a total of 10 new liaisons that are working to do community outreach, awareness, and education when it comes to behavioral health, looking at stigma and partnering a lot with the community to do collaborative efforts to get information out and to link to services. Another something else that has happened in the past year from PEI is May is Mental Health Month, and Suicide Prevention Awareness Month offered a calendar of virtual activities. Also new this year, on our Up to Us Riverside webpage, we offered mental health and wellness kits for the first 250 Riverside residents who visited the site and filled out a one-time questionnaire form. The kits were met with enthusiasm and they sold out by the 2nd week of May. For the year 2021, the Up to Us Riverside webpage saw 178,000 visits to the website, and that was 156 unique visitors. So we had 156,000, I should say, not just 156, but 156,000 unique visitors, meaning that these are people who had not been to the site before. So that was really exciting for us. We know that it was in the season of COVID, and so people were being more electronically interactive and using websites as a ways of communication. And so we were happy that we had information available for prevention and early intervention for people during that time. And it looks like a lot of people were able to access it during that time. For work plan 2, we're going to go to work plan 3 for PEI. That's families in schools. So due to COVID, our UHSBH staff access to students in virtual school was extremely challenging. The Peace for Kids staff were redirected to support large community needs and outpatient clinics while schools adjusted to meeting student needs during the pandemic. This provided the opportunity to reevaluate the project. So the Peace for Kids program will no longer be provided by our UHS staff. Instead, the program will go out on a competitive bid specifically to the school districts. The goal is to have Peace for Kids program in at least one school district per region. So that is our new goal. Again, COVID made us see some challenges. We were able to try to navigate ways around that, and we found that because we did not have access, the schools actually had access. And because we are so community focused, why not hand over these contracts to the schools, allow them to bid for them, and be able to provide the children that they service and see every day with mental health services through prevention and early intervention through a contract with us. And so that's the way that we have that going now. The contracts are going out for bid for school districts to apply. Number 4 is TAY project. So number 4 is transitional age youth. Remember I said that that's the group of individuals who are between the ages of 16 and 25. I have a note here from our prevention and early intervention manager about that. The Directing Change statewide program and field contest for fiscal year 2020 and 2021 included 40 Riverside County film submissions from 13 schools and 97 participants. Riverside County won first place in Mental Health Matters through the lens of culture and sanamente categories. This year, Directing Change added a new category called Hope and Justice, which is a monthly contest for a variety of media entries. Riverside County Youth won first place in October and November of 2020 and of April of 2021. So our youth are doing a whole lot of great things by being participants in this Directing Change video series, which is videos that they put together. It's a statewide competition. So there's videos that they put together that talk about mental health, stigma. They talk about interventions and different things like that. So we have some pretty talented youth here in the county of Riverside, and our PEI team is honored to be able to work with them with their putting their video selection together. The last note that I have, oh no, it's not the last. I have another note from PEI for work plan number 5, first onset in older adults. So COVID restrictions increased isolation among older adults, a leading cause of depression. The program to encourage active, rewarding lives for seniors, which is called PEARLS, Program to Encourage Active, Rewarding Lives for Seniors, is an in-home depression prevention service that focuses on problem solving as well as behavioral and social activity. In fiscal year 2021, PEARLS started the PEARLS Club for participants who have completed the program to get booster session and connected virtually, socially with others from the program. They did monthly events on Facebook Live related to PEARLS and provided psychoeducation about depression management. The PEARLS team partnered with the Indio Senior Center to participate in monthly virtual activities, presentations around depression to help engage the fight of isolation. So that was something that was initiated, another thing by COVID, that was initiated to help seniors who felt isolated and dealt with a lot of depression during that time. And that way they were able to do some Facebook Live social gatherings. And so PEI wanted to mention that. Now, the last work plan that I'm going to go over for PEI is the underserved cultural populations and some of the activities or contracts that they have around the underserved cultural populations. The BRAF program, which is Building Resiliency in African American Families, now includes a girls program, and formerly was just for youth boys. Now includes girls program in both the Desert and Mid-County region. So we anticipate expanding the girls program into the Western region soon. Another project that they have going on is the long anticipated Native American project, Strengthening the Circle, has begun implementation services after the competitive bid process. So it went out to bid, we were able to secure a contractor to do it, and so Strengthening the Circle has begun. The Mamas y Bebes program has expanded to the Desert region, making the program now available to pregnant and newly parenting Latina and African American women countywide. So at first we were only in Mid-County and Western region with the Mamas y Bebes program, and now it is in the Desert region. So that's my updates for PEI. I can go on to the next slide. So for WET, WET stands for Workforce and Training, Workforce Education and Training. So original WET funds were one-time funds, and those expired in 2018. And so now WET is sponsored by our community services and supports dollars. WET recruits, retains, and develops the public mental health workforce. So WET has a total of 5 work plans, and I am going to talk to you about work plan or bullet number 3 that I have here. RUHSBH Adult and Older Service Older Adult Systems Volunteer Program. I apologize for reading that incorrectly. So that program has improved infrastructure, coordination, management, and evaluation, including updating and standardizing administrative practices, and it's expanded of its placement opportunities. So that is the major update that I have for WET. We can move on to the next slide. Innovation. Innovation, again, that's the team that I manage. And so when it comes to innovation, we are 5% of MISA funding. So 5% of that MHSA funding goes to innovation. It's a combination of funding from community services and support and from prevention and early intervention. Innovations projects are time limited. They're only 3 to 5 years. And they are essentially research projects. So much like we have medical research in the field of medicine, when it comes to innovation projects, you can look at that as like medical research, but in the form of behavioral health. So we're looking at interventions, we're looking at solutions for mental health services, and is not to fill service gaps. We cannot use the funding for that. It's largely community-based. We have to go out into the community. It has to be a community-defined research project and ask the community what those needs are and what we need to address. And then we bring the community lived experience back into our office and work with the experts in mental health. So it's community experience plus expertise equals an innovation project plan. We put those plans together. We then ask the state for approval. Again, the funding is already set aside for us, but the state has to make sure that what we're doing is community focused and that it really is innovative. It's like we can't do something that has been done before. And so with all of that said, we are in the process of creating new innovation projects currently. And we hope to be able to go to the state by the end of the year to be able to to ask for permission for use the funding for those projects. The current projects that we have right now going on are our CSEC mobile team, which is our commercially sexually exploited children program, as well as our tech suite, which is our help at hand program, which looks at using technology as an intervention for behavioral health services. So there was an app that was created called Take My Hand, and that gives you peer chat to anyone who would want to, who might feel like they want to talk to someone. So there's peer chats available. It's absolutely free and it's open to anyone throughout the county. And that's by going to takemyhand.co. So that's the update I have on innovation. Next slide, please. So this capital facilities and technology is what CF/TN stands for. I have a few bulleted points that I want to talk to you about that were given to me. The first update is the place safe haven renovation. So the place is a 25-bed permanent supportive housing property for chronically homeless consumers with 24/7 on-site supportive services in Riverside. Major renovation of this property started in the spring of 2022, and anticipated completion is in late 2022. Renovations will increase bed capacity from 25 beds in shared rooms to 33 beds in single rooms, increasing the group space in common areas, and provide much needed updates and upgrades to the building's infrastructure and living space. Another one that I have for you is Hemet Recovery Village. It's in the planning stages. Hemorrhage Recovery Village is a community of care that will include supportive housing, residential services, and outpatient services. The third that I have is Mental Health Rehabilitation Center expansion, 21 more beds, which is really exciting. The Riverside County Telecare MHRC went from 38 to 59 beds substitute residential program located in Riverside. The program provides long-term mental health recovery services with a supportive structure and secure inpatient environment designed to help clients prepare to move into the community and or lower level services of care. So that's really exciting. The last one that I have is Restorative Transformation Center. It opens in the summer of 2022, so in the summer of this year. It's a residential facility for social rehabilitation, serving justice-involved consumers who require long-term psychiatric stabilization and are awaiting completion of restorative diversion program, as well as adult consumers who are challenged by their illness to live independently, but can be cared for in a home-like social rehabilitation program. So those are the updates that I have for you for community supports and services. For capitals, facilities, and technology. Next slide, please. So what's next? What's next is in April, we're doing a 30-day posting. That actually happened on Monday, on the 11th. So we went live with our plan update. We are going to be having a public hearing. We're still talking about if it's going to be like last year where it's only virtual, which we have already recorded the videos. So if you want to see our public hearing, they'll be posted in May. You can hear my voice again reading slides. There's also, we can do a hybrid. So we're seeing how open we're going to be able to do some in-person public hearings as well in each region of the county. I want to let you know that all of your comments are documented. So whether you call into our phone line, submit a form, go online and do the form electronically, we have to include all that information into the plan. So the plan is posted, then we get the community comments and feedback. We include 100% of that feedback into the plan, and then we edit the plan based on community feedback. And the Behavioral Health Commission reviews every single comment and responds to those comments in the plan. Next slide, please. So this is a little bit of what I was saying just in the previous slide. With COVID-19, we were able to successfully actually do some virtual public hearings for the first time, and it went really well. We were viewed on our social media. In 2020, there were 16,000 countywide views. In 2021, there were 12,000. And so in 2022, this year, we're thinking of still keeping we actually have already recorded to keep it virtual, but we might be doing some in-person public hearings as well. Next slide. So where can you find this information? If you go to our website, which you will see the website address there, it is rcdmh.org. You click on Mental Health Services at MISA, that MHSA, that's for Mental Health Services Act, and then MHSA Plan Update. And there on the right side, you'll be able to find something that says give feedback, and you'll be able to give your feedback there. If you just want to research the plan is posted there. You can look at the plan as well. Next slide. There's some contact information, and I can make sure that everyone has this. I will actually send this presentation over in an email so that everyone has access to the presentation as well as the contact information. However, if you have questions about any of the sections that I've talked about, you can always reach out to us. Our general MHSA information is there. You can reach out to my administrator, David Sholin, and he's there. With his email address. My colleague, Diana Gutierrez, she does prevention and early intervention. Our wet manager is vacant right now, but if you have questions about wet, any of us can answer those questions. When it comes to innovation, my information is there as well. as and then cultural competency is not listed, but I can handle any questions about cultural competency as well. Thank you all so very much. I hope I didn't go over my time. I tried to narrow it down and just hit some bulleted items because really it takes us about a good 45 minutes. I'm very appreciative of the time and being able to get this information out to the community. And if there's any questions, I can take those now.
Tonika, you did great. I'm smiling because I've been there like you, trying to like plug in an hour presentation into 15 minutes, but you you did a great job and you got us excited about a lot of the new centers that you guys are going to be opening. I do see that we have a hand raised by our very own vice chair from our Continuum of Care, Karen Roper. So we'll let her ask her question. Go, Karen.
Thank you so much. Great presentation. We're so supportive of all the important work that you guys do in this important space. So first of all, please accept our thanks. It's difficult work and you guys do it well. I have a couple of questions I wanted to ask you. The first is the housing component. Do you have the option to use that for bricks and sticks to finance affordable housing, or the restrictions? Can you explain the restrictions?
When it comes to MISA funding in housing?
Yes, I believe you talked about that the MHSA has a component for housing in the earlier part of the slides.
Yes, so HOPE is part of our housing program that falls under MISA. And I am not an expert in that, but you do have an expert coming on next who might be able to answer some of the questions of how MISA funding is using in the HOPE program. I can't answer that question, but I can get that answer to you. Okay,
so I have two other questions. One is how in terms of assessing the MHSA revenues over time, are you guys seeing overall corporately for our county an increase or decrease in the revenues? Because I know there's so many big gaps to address mental health. So how are the revenues pacing? Because I know it's based on millionaire tax, and I know that there have been a lot of people moving out of California. So I'm curious to know how the revenues are pacing for our county.
So now they're current and stagnant because as we receive funding, it's a couple of years behind. Oh, I see Dr. Chang has his hand raised, so I think he wanted to chime in too. Oh, no, but we haven't seen the impact of COVID just yet, or the impact of the what would you call it? People in flight, people leaving California. We haven't seen that impact yet when it comes to our MISA funding coming in, but I think Dr. Chang wanted to speak on that as well.
No, thank you. Thanks, Tony, and thanks, Karen. I think it's a great question. The only point that I wanted to add to that is just as a a 2-second refresher. As a system for the county of Riverside, we're short about $150 million each and every year, and that's comprised of 91 realignment, 2011 realignment, and MHSA, which we're talking about here today. From a high level, we have about 6% of the eligible population for MHSA, and we get about 5% of the funding, which is better than 91 in 2011 proportionally, where we have about 6% of the population, 3% of the funding. But when you talk about such large dollar amounts, each percentage is a huge chunk of funding, and also allows us to then leverage additional state and federal funds. To answer your specific question, Tony answered it right on. Like, we don't know as of yet. I think the point I wanted to make is just highlight the challenges there are in planning from a fiscal perspective when it is such a volatile process. So maybe, millionaires flee California. Maybe they realize capital gains. Maybe they don't. And so we really are at the whim of a lot of forces which are beyond our control. And the downside further on that is that the amount that is put into the pot conceptually is then split 58 ways, and our slice of the pie is not so great. But so it's hard to plan. I've heard presentations by people who that's their entire job is to forecast, and they'll tell you that it's sort of it's just really tough to predict. I think we've had a better run previously, but it really just depends on what millionaires choose to do, and what legislation is passed in terms of taxes and capital gains taxes and all this all this type of stuff, which is beyond our departments and the county's control. So we obviously keep a very close eye on it. Yeah, and that's sort of just the part that I wanted to speak to.
Well, Dr. Chang, just one last thing. If I know your staff mentioned that the state reads the comments. If you all can let us know how, as the continuum of care, we can be helpful in making important comments to support you in these gaps. Since the state reads the feedback, we'd love for you to tell us how we can be supportive to you and make those comments corporately as the continuum of care.
No, I appreciate that as well. And I think the other part, I just wanted to put in a plug for the team that despite, and Karen, you asked, and I'll let Marcus speak specifically because he knows this better than I do, but you asked about funding that can be used for bricks and sticks, brick and mortar, like actual housing. During COVID, we actually opened 315 or 316 beds throughout the full continuum of care, different levels of care. And that's despite all our funding challenges. And that was, as far as we can tell, the highest number of beds in the state, for the county behavioral health department. And we think, and this part's the part that's not verified, we have to check, we think it's almost more than everyone's put together combined of the other 57 counties. I think that we were focused very heavily on this, especially with the challenges with COVID and being part of the RUHS system. We were tasked with really expanding our capacity quickly. And transparently, some of these projects were in various stages of completion, but we tried to rush them to opening so we could benefit from them. So specifically, I know Roy's opened early, some of our other projects opened early, and they have been hugely helpful to the community as a whole, we believe. And then the last thing I'll say is Tony mentioned the recovery villages, which we're super excited about. And actually, that might be something you all can help us with in terms of a letter of support. And this is we're looking to build 2 recovery villages this go around in funding opportunities, one in Hemet and one in Coachella. But we, again, think that will help build out bed capacity and continuum of care from our definition of continuum of care, not the COC meeting today. So thank you.
Well, Greg, I think we can definitely coordinate that, right? To get them the letters of support. You and I can sign that. We'd love to do it, right, Greg?
Yep.
Okay.
Being mindful of time, we'll go ahead and move on. If you continue to have questions, put them in the chat box and we will get them answered at the end of Marcus's presentation.
All right. Thank you. Marcus, I see that you're already turning your video on. I just wanted to do a short introduction. Many of you have had the pleasure of working with Marcus and his team. They are oftentimes the first team we think of when we come across someone who is in crisis and not just experiencing a behavioral health challenge, but homelessness in general. So we just want to acknowledge his team. Aside from street outreach, they also receive funding to administer permanent supportive housing projects that are funded through our HUD Continuum of Care program, which is separate from what Dr. Chang was speaking to earlier. But welcome, Marcus. Pleasure to have you.
Thank you, Tanya. Thank you, team. Between Tony and Dr. Chang, it's a tough act to follow. So I wanted to share with you a little bit, not just about the HOPE program, but hopefully I didn't miss the mark in what I put together here. But my understanding had been, I wanted to share with you a little bit about how to access behavioral health services in general for your clients, because I know that the programs that are represented on the call today might be serving not just homeless clients, but clients who are now housed and need services. And so I tried to lay this out in a format that could be useful for those who aren't on the call today, just to have sort of the highlights, the most basic step-by-step guide of how to get people connected to our services. We are a very large system of care. We have 75 plus county clinics and then over 100 contractor sites. So as much as we wish that there could be just one front door, there are multiple doors to access services. And that's a double-edged sword. In some ways that's good, lots of different ways to get connected, but sometimes I know that can lead to confusion. So we'll dive right in. like Tanya shared, my name is Marcus Cannon, Deputy Director for the department overseeing forensic services, but today here talking mostly about housing and homeless services. We have a CARES line. This is, as you can see, an 800 number. It's meant as our biggest front door. If you need somebody to get connected to services, mental health, counseling, therapy, seeing a psychiatrist, getting access to medication, getting a screening for substance use treatment, somebody with addiction problems, this is the primary number. It's staffed by clinical staff, including clinicians. They can do screenings and assessments over the phone and then make appointments at our various, all those 200 clinic sites that I mentioned to get people plugged into all those different levels of care. I think if we can go to the next slide, I'll save questions until the end and I'll ask for help from the COC team. For some reason, the chat isn't working for me, so I can't see questions in the chat. So I'll ask for help at the end on that. I know we often get calls with questions about from member agencies that are on the phone and they state, hey, we have someone that seems in crisis. It doesn't seem bad enough that we need to call 911, but we also feel like CARES isn't the right number for us. We're not looking for an appointment, 2 weeks from now. We think this person needs to see somebody today, tomorrow. What should we do? So this is the slide to speak to that. We have 24/7 mental health urgent cares. They're in Riverside, they're in Palm Springs and Paris. And same way you would think of a physical health urgent care, think of the mental health urgent care in the same sense. Right? If we have a physical health problem, if we're gushing blood, if we've been shot, we don't go to urgent care, we call 911. If we think, oh gosh, it's about time for my annual physical, we call our doctor's office, we set up an appointment. But for those things where we think, man, I have this really high fever, I feel dizzy, like I think I need to see somebody today. I can't wait to see my doctor in a week or two. We go to physical health urgent care. Mental health urgent care is the same thing. Things that are urgent, but not life-threatening emergency. The phone numbers are on there. If you go to our website, there's all the addresses. We also have a complementary set of facilities that are called crisis residential treatment, and these are 14-day mental health residential treatment facilities. The best way to get access is through the mental health urgent cares, and so I didn't list separate phone numbers, but I just wanted people to know that for people who go to mental health urgent care, a lot of those visits can be completed same day. The person can see a prescriber, get access to a medication refill, talk to a therapist, get an appointment booked for follow-up at an outpatient clinic, and they're on their way out the door. But there are people who it's apparent need more care and a longer length of care, and the mental health urgent cares will work with these crisis residential treatments, these 14-day programs, to get somebody in so they have some longer term stability and treatment of their mental health condition. And during that time, staff will work with people to try to figure out, the longer term mental health, behavioral health care that they need. Could we have the next slide, please? Dr. Chang mentioned quite a few different beds that opened up during COVID. This is another example. We opened a facility called the Arlington Recovery Community, and there's an attached sobering center. The sobering center is 24/7, that people who are intoxicated can come in and get screenings for longer term substance use services. There's also some basic services available while they're there to make them comfortable, a shower, laundry, a meal. But the biggest goal is to try to allow people to sober up safely so they're not out on the streets and, a danger to themselves or danger to others, and then to have them talk with a counselor and get into longer term substance use treatment. The Arlington Recovery Community is that longer term residential substance use treatment there on the same campus. But we have quite a few different residential substance use providers across the county. And so somebody who comes into the sobering center might end up right next door at the ARC. They might also get referred out to one of the other facilities across the county, depending on what their indicated clinical need is and other, population specific characteristics, a men's facility, a women's facility, a detox. but we're really excited about this. ARC is 54 beds and the Sobering Center is 15 beds. It's the first of its kind in the Inland Empire. The biggest thing I would say here is, as you all know, as continuum of care partners, you try to develop services and housing, and you know that those are always met with a mixed reception from your local city. People want services, but there's always the fear that, you know, sort of the if you build it, they will come fear. And so the biggest thing that we need your support on is if you have a client who's intoxicated, who you bring to the sobering center, we need and expect your help in discharge planning to get them back home. The biggest way the sort of, it's like a double negative I'm trying to say, but the quickest way for us to shoot ourselves in the foot, and not just behavioral health, but all of us as providers, is if we launch a service in a city and then that city has evidence that this is bringing new homeless people to the area, the city will say, you know, no more, this doesn't work for us. So whenever you're bringing people to us, we need your help in getting them back home. Next slide, please. I think Tony covered some of this, but we really have a robust PEI division, prevention and early intervention. And so they've got multiple web pages dedicated to suicide prevention, mental health awareness. I just took a little snip of one page that I thought was relevant because of the suicide prevention resources here. Melanie, I'm sure will share this presentation out afterwards. The links are clickable, so you can go to the web page by clicking on these links. But there's really a lot of information there about mental health resources in general, but especially about suicide prevention. And I know myself and our staff often get calls from COC members saying, hey, this person's in our housing, we're worried they might be suicidal, or they've said that they've committed suicide in the past. How can we connect them to support? This is a great place to get more information. Next slide, please. We serve as the lead agency for the county's coordinated entry system. We provide updates about this at each of the COC meetings, so I think in the interest of time, we'll probably move along, but this system, for anybody who's on today who's not familiar with it, serves to provide access, screening, prioritization, and referral to continuum of care resources. So you could think of it a little bit like 211 for homelessness. We have a 24/7 hotline that people can call and get more information about how to access homeless resources. Next slide, please. We have homeless outreach teams. And Tony again mentioned this a little bit. There's a variety of different types of these teams. Some are focused exclusively on homeless, others kind of mix homeless and crisis, others mix crisis and law enforcement. So the department has really tried to expand the number of teams, and our team as a whole, my colleague Ryan Miller and others have recently gotten grant funding to really expand the number of different types of mobile teams that we have. CBAT are teams that are a clinician, a licensed mental health clinician riding along with a sworn officer. Those teams are growing exponentially. There's one coming to, seems like nearly every city, but quite a few more across the county. And then likewise, we have mobile crisis management teams that are 4-person teams of a clinician, a peer, a drug and alcohol counselor, and a case manager. And those teams are expanding to quite a few new cities, designed to do both homeless and crisis work. And the easiest way, if you need, you say, hey, there's this encampment, we're not sure if anybody has been out to see it, call us at the Home Connect number that's listed on this slide, and our staff can figure out whether it's most appropriate for a behavioral health team to respond, or we very much work with your organizations, because quite a few of you are also funded through the continuum of care to do street outreach. And so our staff will often get those calls and say, oh, it's in this area. Well, Step Up is contracted in this area. SWAG is contracted in this area. CityNet is contracted in this area. And our staff will reach out to the outreach coordinator from that organization and get a response. Next slide, please. I think I kind of covered this already, but this is really exciting how much expansion we're seeing across the mobile crisis services. And I should mention that they also provide services at hospitals and schools as well. Next slide, please. We have quite a few different locations for permanent supportive housing. Some of those are tenant-based, where people have vouchers and they can, find housing of their own. And then we have project-based locations, and I put a number of those project-based locations here. Karen raised the question earlier, can MHSA be used for capital projects for housing? Yes, it can, and we certainly have used that. And as Dr. Chang alluded, I don't know the 300 number exactly, but I can think of quite a few different projects that opened during COVID. Permanent supportive housing, mental health rehabilitation center, Roy's adult residential facility, recovery residences, all of which had an infusion of support from MHSA capital dollars.
And Marcus, can I just jump in for 1 second? Because I think I misunderstood Karen's question. So MHSA does have a capital component, and we build capital projects out of that. I understood Karen's question to be more related to H Hope specifically, but maybe I misunderstood the question.
So I was just harkening back to when MHSA was first established, and it would provide for, at least from my experience in Orange County, there would be financing, like gap financing, and there would be like a COSER for an operating subsidy. And there was like a set amount that was set aside. But obviously, MHSA has evolved through the years, so I wasn't sure.
Sure, I can speak to that.
Changed.
Yeah, Dr. Chang, I saw you start to come off mute. I can speak to that if you'd like. Okay. Yeah, at the very beginning of MHSA, there was a set aside housing allocation that was administered by Cal HFA and allocated down to the counties. Many counties were not able to use their funds and had to return funds. I'm proud to say that Riverside County used every single cent of those funds. And we built 7 apartment complexes with it. They're in Riverside, Paris, Menifee, Moreno Valley, Desert Hot Springs, Thousand Palms. And they continue to operate to this day. There's a 55-year covenant of affordability on those properties. And we have on-site behavioral health case managers at those locations. So that money was used, so there's no more money to use out of that pot, but I'm proud to say that we used it and didn't send it back to the state like some counties unfortunately had to do. Next slide, please. I hope that answers the question, Karen. We have augmented adult residential facilities. The common term for this is board and care, but they are licensed by the state, and this is the technical term. This is sort of our highest level of residential unlocked care. Here, residents would have assistance with reminders to complete their activities of daily living. Yeah, their medications provided to them, meals prepared. So it's not permanent supportive housing, but it is long-term for those who need it. And they tend to stay full. We're certainly looking at ways to expand this. Dr. Chang mentioned recovery villages. That would be part of that recovery village concept, is to add additional facilities like this. We could talk for a whole hour about sort of the through flow of how having facilities like this improves our inpatient psychiatric facilities and improves our ability at the outpatient level. Obviously longer than we have time for today, but I know people hear about these facilities and are curious. So I just wanted to mention it here in this slide and highlight that we have 2 facilities currently, one in North Palm Springs, one in Indio, and then looking to expand. Next slide, please. And last, there was a question kind of as I got ready for this presentation about, well, how do we get access to healthcare? Obviously, there's multiple healthcare options people can choose in the county, but we're proud of our community health centers. There's 14 of them. Again, this is a clickable link. You can see, go to the locations to make an appointment. They provide both primary care as well as specialty care, physical health care, dental care, and then they also do serve behavioral health consumers. They don't provide services for the consumers with the most severe behavioral health needs, like our standalone clinics, but they each have a clinician and a psychiatrist attached. So just the way that you or I might go to Kaiser or something and see our primary care doctor, but also we've been experiencing some depression, and we walk out with a prescription for Zoloft and we see a therapist. There's that kind of integration within these community health centers that people can get both physical health as well as mental health needs met. So I wanted to add that in because I know that across our continuum of care, as we look at our HMIS data, our formerly homeless consumers don't have the best lifespans. And oftentimes that's due to treatable primary care conditions, cardiovascular disease, metabolic disease, the same things that you and I will die of probably, but a lot sooner, sadly. And so if we can get people into primary care, I think that's a huge boost to our continuum of care. I think that's the last slide. Oh, I think we're out of time, but for people who have this presentation, if you have questions, you want to reach out. These were just a couple other things that I wanted to highlight of ways that you can ensure that you can best work with the behavioral health department to, get information back and forth about how to serve your consumers well. So I apologize to run over.
That's okay, Marcus. I appreciate you speeding up to fit into the allotted time. We did have one question in the chat box that wasn't answered, and that's, is the MHSA funding subject to Housing First? So you can mix sober and non-sober residents in the same program.
Correct.
Tony, I don't know if you're still on to answer that.
I can answer that.
Okay.
Yeah, I mean, it's state funding. And so the state essentially expects that any housing that you do with state funds, you align with Housing First. But I think what I would say is that just like any Housing First project, there's still an owner and a property manager, and residents are expected to abide by the terms and conditions of a lease. So you're not required to be sober. You're not required to have a certain attendance record with your medical provider in order to have access to the housing. But to keep your housing, you have to be a good neighbor and pay your rent and behave respectfully on the property, just like any resident would be expected to do.
Thank you, Marcus.
Yes, absolutely.
And as a reminder, our next webinar is May 12th. It will be on Foster Youth Awareness Month. So we will have presenters about foster youth programs. All of our webinars are recorded and posted on our website, as well as a copy of the presentation with all the links that Marcus has in here for anyone that needs to access those. And someone asked, is there a one pager available with these resources listed out?
No, because it wouldn't fit on one page. I can ask our team, to think about what the most cogent way is to try to bring things together. But again, I would say, that's the curse and the blessing, right, of a department with 200 clinics. There's not really a way to put that on one page. We have a web page. I would encourage people to go there and, look for what they need specifically. But I will think about a way to try to put out a one pager that would be most useful to the COC.
All right, I do have just a couple quick questions in the chat box. Does your outreach team have staff who are specialized in youth mental health services?
We have quite a few peer staff on our teams who themselves have lived experience. And so oftentimes they may have that lived experience of having been homeless as a youth. I don't think we have a youth specific team.
Okay, and on that same line, is the permanent supportive housing units, or are they specified for youth with behavioral health needs? Do they service youth?
They serve youth. There's no youth exclusive project at this time, but the youth are eligible to live in any of the projects.
All right, and Karen Roper asked if the COC can help behavioral health in developing referral protocols to support the good neighbor policy, so referring agencies help get clients back to community of origin.
We'll always take help. Maybe I can follow up with Karen offline to get more details on the question.
All right, thank you. And with that, we're 2 minutes over, so we'll go ahead and wrap up. I appreciate both our presenters coming on today and giving us a wealth of knowledge. and information about behavioral health programs available in our community. Take care and have a great day, everyone.
Thank you.
Good
Thank you
job,
for having
Paige.
us.